Light off. I don't think light is here. A light go off coming. So, basic idea regarding this class is, first of all, welcome you all to care groups, and you will be having a great time, great opportunity, and great career here. It is a starting point, and it is falling on the same day when we are having our morning session. We are late by around half an hour, so I apologize for that. And the purpose of this class is to know when we are doing we are having one procedure we call as electrophysiology. And the basic idea regarding starting this class that everybody should be aware what basically EP is, how we are approaching, how we are identifying the signals. Because this part is most of the time not discussed in most of the forum. Cardiology is taken as a stenting and bypass. So this domain is underutilized, under rated, as well as misunderstood by most of the even cardiologists also. So when the cardiologist will be going, he will say there is one surgery called EP study. But when they are going to say, when we are going for the stenting, there is one procedure. Chinniga procedure unnai చేతి ద్వారా చేస్తాను. But when they have to inform to the patient regarding this procedure, they will say, one surgery is there, and the time you say surgery, the patient will say, no, no, I am doing good. Why I should be admitted and why I should go for the procedure. So at least our nursing, our technician, and any interested doctor should know how we are proceeding and what we are doing in the EP study. So, so basically the EP study, what we normally do is the normal conduction system means if you are knowing or not, the conduction of the heart start from the SA node, then AV node, and then it start going through the myocardium, through the some what you call fibers we call as a left bundle branch or right bundle branch. So those things we are doing. And during the EP study, baseline measurements we will do. How the like if anything you are doing, you have to measure whether it is normal or abnormal. If it is abnormal, what are the causes, and accordingly we have to treat and identify the disease also. And the discussion what we are going to keep it is regarding the EGM. This is the more technical part, and this will be totally limited for the persons who are very much interested to know the electrophysiology and how we are ablating and how we are finding identifying the signals. So usually EP study, I think these all things has been discussed. So I will go very fastly on those topics. So if you are coming into the cath lab, or we can say EP lab, you will be seeing a lot of monitors are there. Usually in the cath lab, two monitors are there in which we see only the what you call cine images and the fixed images, on which we identify the block is there and we have to put a stent. But when we come into the EP lab, we are having at least three monitors. One will be running ECG, one will be having fixed ECG, means what you call captured information, and then two more monitor of the what you call cath lab fluoroscopy images. These are the four in the conventional EP study. When we are going deeply inside the what you call 3D, then we'll be having two more monitors. So these six monitors we have to you have to juggle from one time to other time. What is the information, where the catheters, all those things we have to do, and then we have to detect that this area is the culprit area. So in this, the most important thing what we have to do is the focus. Where to focus, when to focus, and how to identify the signals. That makes the difference. And that's why the electrophysiology is only and only focus, nothing else. So you have to see one signal and identify, oh, this is the problem. So like seeing the eye, you can identify who the person is. And the same thing goes for the EP study. You see one signal, a lot of informations are going on the monitor here and there, but you will focus, okay, this is the problem. Now I have to move the catheter and make sure that the diagnosis is confirmed. So these are the what you call catheters. Normally we put three catheters. So these like a angiography, in that we are putting a hollow catheter. Here it is not a hollow catheter. It is a catheters with some you can see black points. So these catheters are called electrodes. So these electrodes will be numbered from one up to down, and usually the convention is numbering is start from 9 to 10. So 9 to 10 is proximal, and 1 to 2 is distal. So like that, we will be monitoring the signals from where it is coming. And this is the coronary sinus catheter. This is a right ventricle, his bundle, and RA. So these are 4 wires we have kept in the patient. And by the 4 wire, we are nearly 10, 14, 16, and 4, 20. 20 locations we are identified from where the signals have been coming on the monitor, or you can say on the computer system. And this is a normal conduction system. If you know SA node, AV node, then the bundle of his, and then RN, right bundle branch and left bundle branch, and they will be arborizing, and it is becoming the what you call Purkinje's fibers. So this is a normal conduction, what happens, and this is the way it goes. So basically ECG and EGM, these two words we use. ECG, you maybe everybody is knowing, it is the integrated electrical activity on the surface of the heart, what we are identifying. And ECM is the localized electrical activity in the heart. So when you are putting a catheter inside the heart, you are getting one information which we call as the ECM. It is also electrical, but it's a localized electrical activity. So when we are putting the information on the monitor, that this type of signals will be coming. The surface ECG will be showing lead 1, AV, V1, V6, and we can get all the 12 lead ECG running live, means it will be running. And at the same time, the RA, his, CS, and RV, the 4 catheters what we have kept, all 4 information will be again parallelly running in the same monitor. And then we have to start concentrating how the proximal, how the distal electricity is happening, means electrical activity is happening. And like that, the right atrium, his, CS, and RV, all this information will give what you call information how the electrical activity it is. We use the word proximal to distal. Again, this is atrial and ventricle. So use the word A and use the word V when it is intracardiac. When it is on the surface, we use P and QRS. This is the major difference regarding the EGM versus ECG. So this is a normal intracardiac, and this is the activation we see. So whenever we are seeing the ECG, it will be running, and we will be seeing this is AV, 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 AV. This type of activity is going on. And in between, there is one special catheter which is very informative, which is called a His catheter, because it is lying between the atrium and ventricle and passing over the AV node in and around. So AV node is having the atrial activity, ventricular activity, and His means his bundle activity can be captured. And this will give full information how the conduction is happening. So if you want to know how the electrical system is going and only one catheter is needed, then it is a His catheter. Okay, His catheter will give all the atrial, ventricle, and conduction system information. Why we do the EP study? So we want to test how the SA node is working, how the AV node is working, how the normal conduction is happening, and how the ventricle to atrial means. Usually we know that activation of atrium will happen and then the ventricle happen. But we want to cross check whether this conduction is only happening to the AV node or something else is happening. So it may be possible there is some fibers which may be connecting from ventricle to atrium, and they are aberrant. We call as a aberrant pathway. So that we are going to identify by doing the EP study during time. And there, whatever the patients who are suspected to have the arrhythmia, there we are going to do some protocols, means we are going to give extra beats and we will induce the tachycardia. The same palpitation what he was or she was feeling, it is being re-induced. The tachycardia will be induced, and then its characteristic will be identified. Okay, this is a PSVT, or it is atrial tachycardia, it is a ventricular tachycardia. All those things we are going to do. So baseline measurement we'll do, and the baseline measurement means like if you want to check the weight of a person, what you are using, kg. But if you are in the US and Europe, they will be using pound. Pound, na? So in EP lab, there we will not be saying heart is 80 beats per minute or 70 beats per. We will be saying 1000 milliseconds, 600 milliseconds, 500 milliseconds. So the number going down means heart rate is going up. Simple. And if you want to know if the person is having heart rate of 100 beat per minute, it is 1000 beats. So this is a 60,000 divided by rate. So it will give. So patient heart rate is 60 beats per minute. The 1000 is the millisecond. So we don't use the 60 beats per minute. We will be saying the cycle length is 1000, 1600. Like that, it is going to be used. And the surface ECG will be again conduction system we are again identifying, but there are some parameters which we usually, it is for those persons who are very much interested for the EP study. So sometimes we are very much confused whether it is when you are seeing the ECG, somebody will say VT, somebody will say SVT. So how to identify? So there is, on seeing the ECG, we have to go to the EGMs. And EGMs, one information we call it HV interval. So HV interval gives how much time it is taking from whether the AV node is activating first, either parallelly or we can say serially. If the ventricular activation is happening through the his, so first his will be coming and then the ventricle. And there is a time gap between the AV nodal activation followed by the ventricle. But it can be possible that ventricle is activated first and his is activated later on. And this type of conduction system problem we call as a WPW syndrome. So in those situations, we use the one ventricular pre-excitation, means the atrium is activated at the same time ventricle is also activated. It is bypassing the AV node because there is a aberrant fibers. So that's why the HV interval, we use the word HV interval will be short or negative. Usually in most of the condition, any condition, it will be always positive. If it is going towards negative, means there is some abnormal pathway between atrium and ventricle. And same thing is for the HV. So we want that atrium and ventricle should activate in a particular time frame. It is given that, okay, up to 35 to 55 minutes, it should activate. If it is taking 75, it is taking 100 millisecond, means there is a conduction problem. Either it is a block or it can say there is a fibers are not healthy, they are diseased. So we call it the AV conduction disorders. So that can be identified by just doing the only one parameter, that is HV. That's why I was saying your his catheter give the most informative of all the catheters. And how to measure it? So it has already been discussed how to do it. It is surface ECG, and we have to see the V interval. And then we start measuring each and every parameter, AA interval, AH interval, HV interval, and the baseline measurement. This all has been discussed. So when we do the EP study, we have to know the initial word of how the basic cycle length is, and after that, how the cycle length has been changing after the conduction system. So all the parameters, we are again checking it. So in this, if you can see, there are 4 catheters are there. 1, 2, 3, and 4. One catheter in the CS. So how the atrial and ventricle activation is happening, we can see by this one. His catheter, as you know, it gives the additional information regarding the AV nodal, ventricle localized, atrial localized. All information we can just deduct it. And these are the activation pattern which we see. So this is a normal activation. And now we started the measuring each and every parameters. So this measure parameter in this patient, the AH interval is 60 to 120, so it is almost normal. Then HV interval we are measuring. It is usually between 35 to 55. So this all about the previous class. Now we are going to the class number 2, means this was only the recap. So when the patient is having low heart rate, we call it sinus bradycardia, or sinus bradycardia can be due to the SA node or AV node. These are the two areas from which it can happen. And we have to identify what is the culprit and how to treat, because the type of treatment depends on the type of disease. So sinus nodal disease is the means when the SA node is not functioning properly. This is also by seeing the ECG sinus bradycardia, it is very easy. If it is secondary means if any cause is there, like the patient has received a drug, there is a metabolic abnormality, there is an infection, there is a viral pneumonia, like those, in that it can happen. These are called secondary sinus bradycardia. But there are situations in which the sinus node is diseased. It is not able to form the number of impulses which it's supposed to be. So we use, there are some condition and there are some what you call words we use. So atrial fibrillation is a part of that one, means patient can have sinus nodal disease and at the same time atrium is also disease giving atrial fibrillation. It can manifest as a pauses, means you can see there is a long pause is happening, there is nothing. Whenever the pause will be having, something will take over, means president is not there, prime minister will take over, like that. So the other means SA node is not functioning, then what is the next AV node? Very good. So AV node is the second tissue which has to start giving the beating. After AV node, what is the next? Yes, bundle of his, then bundle of branch, and then ventricle. So because ventricle is the last structure to give the conduction, it is not supposed to be the structure to give beating. But if at all it is beating, it is not predictable. It can stop anytime. So Brady evaluation, how we have to do means if the heart rate is low or we are suspecting the patient heart rate, how to evaluate in the EP study. Sorry, I am going back. So there is one terminology we use, sinus nodal recovery time. So when anybody is working very hard, if it is young, he can do a lot. But if it is becoming old disease, to give some after that, he will be what we call past ho gaya. He will not be able to do the things. So same thing we are going to replicate in the our EP lab. We are pacing, there is a SA node, it is giving beat of 60 beats per minute, whatever you can say. And we will start giving a beat of 100 beats per minute, making it silent. I am working very hard. Now you should say. If it is a young or healthy SA node, the time we stop it, it will take very short time and it will start recovering and it will start beating again at 60 beat. But if it has grown older or it is disease, it will be sleeping because it is not in the state to recover very fast. That's why your sinus nodal recovery time. Older the SA node, disease the SA node, it will take more time to recover. And same thing we are going to do in the EP study. So this is one of the we use the word Brady protocol. So in this, you can see we are measuring the when we are pacing, means pacing from the right atrium, and after that, how much time it takes for the next beat to come. So this is the recovery time it is happening. So recovery time, the 1117, it is taking almost around, the heartbeat is around coming 54. And so we are again, the beating means first time 100, then 120 and 150. Three pacings will be giving. And every time we are going to measure the how much time it takes the gap between the last beat paced and how much time it taken the recovery. And we are going to subtract it. Subtract it means if the heart rate is around 1000 beats and it is taking 2000 time, 2000. So it is 1000 additional, means it is taking 1000 more seconds to recover. And the critical value we use as a for measurement is 525 millisecond. So if the recovery time taking more than 525 to the basic cycle length, it means it is significant and he need a pacemaker. Simple. So recovery time should not cross more than 525 millisecond. So SNRT positive means when we are paced, it is taking almost 525 millisecond over the base rate to recover. That is significant. Okay. This is regarding the SA node. Now coming to the second interval, we call as a HV interval. So AV node is functioning or not, his bundle is functioning or not. AV node is up, his bundle is next, bundle branch are third. So these are three level of blocks we can expect. So if the block is having at AV node versus his versus SN, bundle or below his, we have to identify. And the word we use is suprahesian, infrahesian, and intrahesian. Block is at the AV node means suprahesian. Intrahesian means it is his bundle is not proper. We have to pinpoint because the property of the blocks and the behavior will be totally different. So his is the important structure. EP revolve all around the his. It is like a queen. Everybody is revolving. How is the easy pre post? How it is behaving during taking Brady? All those information is his. So king is his. Queen is his. Okay. So in his, when we have to again identify the blocks, we have to identify whether it is above the his, means patient we are having time. We can give some more time for putting a pacemaker. It is usually secondary and the damage is not that bad. But if it has happened to the his bundle, means when you are doing the EP study or any type of ablation and his time has prolonged, means we have damaged the what you call conduction system badly and he needs pacemaker. And sometimes the diseases all will also be specific. Supraesian means AV nodal disease. So how to identify it? This becomes a important what you call evaluation during the EP study. So there are some set rules we follow it, and it is uh, uh, easy, not that difficult. So what we have to see that when we are seeing his lead, you are having A, H, and V. So in this A, H, and after that V is coming and HV is getting prolonged. Here A, H, and there is no V. No V. QRS is gone. Means there is a block. That is clear. Now the second question comes whether it is a infrahesian, suprahesian. Suprahesian. Why? They all are electrophysiologists. You have brought a right people in this one. Hmm? Suprahesian or infrahesian. It is infrahesian. A reason, see, from here the conduction has gone A, his, it has reached to the his, and after that his, it has not been there. So it is infrahesian. Up to his, the conduction has happened. After his, not conducting. If it is not there, if this his fiber is not there, then it is suprahesian. The presence of his means it is infra. Absence of his means supra. So easy? Difficult or easy? Now, how intrahesian? Suprahesian, you can identify, you can, who is the technician, because you are seeing this patient need pacemaker. Already you have damaged his. You are getting his signal, after that nothing, means already his conduction has been diseased, gone. Hmm? After, if you are getting this his, sorry, A, and followed by, there is no his in the his bundle, it is suprahesian. Okay, this part is not that difficult. But intrahesian is not for means who are in the initial part of your career, initial part of the career as a doctor in the EP, to identify and give the reasoning. So don't worry, if you are not knowing, it is not a big deal. Usually whenever we are dealing the his is having two signals and it is split signals, and the timing between the two signals will be less than 30 milliseconds. So if it has crossed 30 milliseconds, you are getting a his, which is fractionated, and the two signals, like in this, I have not shown it. This 1 and 2, these two parts is there. If it is separating more than 30 milliseconds, it is an intrahesian block. Means his is been diseased. And below his is the bundles. So you can see here, there are three patterns. You are going to AHV, AHV, AHV. Now second, AHV, AH, infra, supra, infrahesian, infrahesian. Again, infrahesian, normal, infrahesian. Now, AHV, 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 A, no V. What is? Suprahesian block. Take you for the next class. She is looking at me. You are taking my class. Okay. Thank you. Yeah. Tea is ready for everybody.